Hello, and welcome to Hard Conversations. This is a podcast about male sexuality, intimacy, and sex positivity, where we unpack the taboo topic of erectile issues in a safe, non-judgmental space. And now, here's your host, sex therapist, Timothy Norton.
Hello, and welcome to Hard Conversations. Today's guest, Joshua Gonzalez, MD, is fellowship trained in sexual medicine and specializes in the management of male and female sexual dysfunctions. These include issues surrounding hormone deficiency, menopause, sexual arousal, orgasm, ejaculation, libido desire, sexual pain, penile curvature, and erectile function. Dr. Gonzalez also treats a variety of common neurological conditions, including benign prostatic disease, voiding dysfunction, and male infertility. Throughout his career, Dr. Gonzalez has focused on advocating for sexual health and providing improved healthcare to the LGBTQ community. Thank you, Dr. Gonzalez, for this today. I really appreciate it.
Yeah, thanks for having me.
Yes. Does your bio leave anything out? You said you were born in Los Angeles. You're from Los Angeles originally.
Yep. Yeah, I was born and raised here. Didn't leave here until I got into medical school. Then I did my medical school training and residency in New York. So I lived there for 10 years.
In New York?
Yes.
Okay. And Columbia Medical School?
Columbia Medical School, yeah.
And were you able to learn about sexual medicine over there?
No. So I think that's a disservice in the medical education. The way that we do medical education in this country, it's really not an emphasis. And I think people who are drawn to sexual health as a career kind of have to seek it out themselves. And so, medical education is very much about exposing students to just the basics of physiology and pathophysiology and kind of introducing them to the different fields of medicine and then allowing them to choose their career path based on that. But sexual health can be sort of approached from several different sort of traditional areas of medicine if you're interested, but you kind of have to be motivated to do that on your own.
And you were?
Initially, not. I didn't really know that it was a field, really. I mean, I initially, the way I got into this was basically in medical school was drawn to sort of surgical subspecialties, which we were made to rotate through during our third year of medical school. So we got to kind of be exposed to all the different surgical subspecialties. And I just really liked urology. I thought that the people that go into the field of urology just tended to be just kind of cool. A lot of surgeons, don't have the best reputations of being personable or humble. But urologists didn't seem to really fit that mold and kind of did seem more genuine to me. And I don't know if that has to do with the fact that we kind of deal with private parts and therefore have to have a certain sense of humor and kind of not take ourselves too seriously. But I just was really drawn to the people. So I decided to go into urology. And then once I got into urology, just kind of looked at the different potential subspecialties within that field and really liked the men's health space. And so when I was getting towards the end of my residency, kind of looked at fellowships that I could focus on men's health and kind of stumbled upon sexual medicine as a field, which involved not just male sexual health, but female sexual health, and ended up doing fellowship in San Diego, doing just that. I mean, focusing on treating male and female sexual dysfunctions. So.
Okay, great. And so I'm curious about this program in San Diego, this fellowship. How many fellowships are there like that in the country?
So that one in particular is pretty unique, meaning I don't think that there's any other fellowships like that in the country, primarily because it does focus on both men and women.
Okay.
So the other fellowships that I applied to, simultaneously were more focused traditionally on male sexual health. So they kind of were a combination of men's health issues and male infertility. So the fellowship I did in San Diego is pretty unique.
So are there a lot of those around? I'm just trying to get a lay of the land.
There's less than 15.
Okay.
I think when I applied to 10 different programs.
Yeah.
They're kind of spread out all over the country. And, it's a fairly small community. I mean, when we have sexual medicine national meetings, it's the same core group of like 200 to 300 people globally that come. So
globally?
Yep. who are considered specialists in sexual medicine. So
Wow. And then globally, do you get the sense that like which countries are more cutting edge or kind of on top of it, or can you really say?
It's hard to say. I mean, I think that in terms of publications in the sexual medicine space, a majority of those are probably coming out of the U.S., but there's, a large interest in sexual medicine in Asia, China, Japan, Europe, certainly. We have some colleagues in South America. There's a lot of people that come out of Brazil who attend the meetings. So there is really a global interest. But I would say, in terms of publications in sexual medicine, my guess would be most of them come out of the U.S.
Okay. All right. Outstanding. So I'm a sex therapist, and if I'm doing my job, every guy that comes in who wants to talk about erectile issues, my first question is, have you talked to a doctor? Have you talked to a medical doctor?
Yeah.
Most of the time, they say, "Oh, I've talked to 4." The last thing I wanted to do was talk to you.
Right.
Talk to me. Talk about the what's going on in the bedroom and everything like that,
Sure.
and that this could be some form of anxiety. So, I actually heard of your name a while ago, and you've got a good reputation in this town.
Oh, thank you.
Yeah, I am very genuinely. I always say that about my guests, but it's always true. I am excited about this interview.
I appreciate that.
What happens when they come here?
So, I mean, I think that one of the strengths that I have in terms of treating patients with these issues is that a lot of them come to see me, and I am the 5th, 6th doctor that they've seen, because I think men, especially, if they happen to be on the younger side, get dismissed. And that's after, months to years of shame that they have had about this issue, if we're talking about erection specifically, where they haven't sought help. So then they finally get the courage to seek help. And, if you get a unqualified provider who doesn't really understand the nuances of how to sort of formally work up erectile dysfunction, then they just either throw pills at these patients, which may or may not be appropriate depending on their problem, or they tell them that they are unhappy in their relationship, or it's all in their head, and that's not helpful for patients because they still they walk away not fully understanding why they have this problem. And so I spend a good amount of time in their first visit just educating them on the various causes of erectile dysfunction, and basically tell them, as their physician, I'm going to focus on primarily the physical causes or potential physical factors that are contributing to their issue, give them solutions to address those problems, and just educate them on all of the factors that come into play when you're talking about erectile dysfunction. And I'm pretty upfront with them in that first visit. I tell them that that anxiety and certain psychological factors can definitely play a role, and I try to make them feel better and say that, in my experience, a majority of men have some psychological component, and it makes sense, because if you're a man who is in a relationship and you enjoy having sex and you want to have sex and you can't, then it's going to cause anxiety, and then you're going to carry that anxiety onto future encounters, and it's always going to be something that you're thinking about and could potentially contribute or make worse any physical issues that are going on. So,
right. Yeah, I think the unfortunate thing is when the doctor who says, whatever, it's all in your head, or this might be stress, it would be great if they had a psychologist next door who they could say, well, go talk to this person today. But we still haven't really bridged that yet.
Sure.
Maybe I'll get an office in this week.
Yeah.
No, but I think we always talk about mind, body.
Right.
And are you getting this sense that we're going to be able to reach across the aisle?
Well, so where I did my fellowship in San Diego, my mentor, who's sort of like the guru of sexual medicine. I mean, he's been in the field for 40 years. Really, his practice is integrated. So he has on-site himself. He has physician extenders. He has like a nurse practitioner and a physician assistant who help him with the medical side of stuff. And then in the same office, he also has a sex therapist and a pelvic floor physical therapist. So each new patient who comes to see him has to see all three clinicians. So they are all seeing him as the physician, they're seeing the sex therapist, and they're seeing the pelvic floor physical therapist. For at least an initial evaluation. Now, not all those patients need to continue to see those providers, but because it is often such an integrated problem, it's a really great model. I think the problem is that he is a fee-for-service practice, so he has the sort of freedom to do that. I think when you're talking about integrating providers and trying to work in the sort of Western medicine model, it becomes a little challenging.
Right.
But I do think it's a very valuable way of sort of treating these patients, because they don't even have a choice. Like that first visit, they're seeing all three providers, even if they think like, no, I don't have anxiety about this, it's all a physical problem. They're still getting sort of screened to make sure that there's not, significant non-physical issues going on.
Oh, it sounds like utopia.
Yeah.
No, it sounds great.
Yeah.
Have you heard among, if you went to a conference like the one you're talking about, anybody else talking about doing things like that?
Yeah, I mean, I think people they see value in sort of an integrated approach. I mean, people talk all the time about like a biopsychosocial model. And so I think there are centers that are being created. It's interesting because I think a lot of it is happening in the female sexual health space, where you're seeing pelvic floor physical therapists working alongside gynecologists who are interested in sexual health, and maybe psychologists or sex therapists or whatever. I don't see it a ton in the male sexual health space. So, yeah, I mean, I definitely think there's a need for it.
Okay.
Yeah.
So maybe briefly, I don't know if there are a lot of different reasons, there maybe hundreds, maybe, but when it's physical and it's very clear, like that you wouldn't have to have any kind of anxious response or any elevated cortisol levels. What are the most typical 100% physical erectile dysfunction
so if you're just talking about physical, I mean, you can break it down into like three basic causes. So you can have a hormonal issue in which, your testosterone, as an example, may be low. And we know that, men's erections tend to function better when they have healthier levels of testosterone. So that's something that's pretty easy to screen for. We just do some blood work on their initial visit. I also pause when I am talking to patients about this particular type of ED, because a lot of them have had testosterone levels checked and they might fall into the normal range. And so that's a point at which they are often dismissed, because their doctor's like, listen, we checked your testosterone, it's normal, this is not a physical problem. The truth is that, they could be in the normal range, but that normal range is pretty wide, because it's meant to encompass men from adolescence until death. So, if you're a 35-year-old guy and you're on the very low end of normal, that's probably not going to be an optimal level for you, being a 35-year-old guy who is having issues with his erections or some other symptom of having low testosterone. So I think a little bit more liberally about that, and I explain to patients, like, I'm not looking for normal or abnormal. I'm looking for, are your levels optimal for what we're trying to accomplish? So that's one physical area that we investigate. Blood flow is obviously huge. I mean, for our erections to work, the blood flow to the erection has to function normally. But what I think some people don't appreciate regarding blood flow is it's not enough to just deliver enough blood into your penis for an erection. We have the ability to trap the blood in the penis. And so that's a unique thing to the penis, because most of the time blood enters tissue, drops off oxygen, picks up waste, and immediately circulates out. But when you have an erection, blood does not leave the system. At least it shouldn't in a normally functioning erection. And so a lot of guys think like, oh, well, I can get an erection, I just have trouble keeping it, so that doesn't qualify as erectile dysfunction. But that's actually not true. So that we have a way of investigating that by doing an ultrasound to actually look at their blood flow in real time when they have an erection and figure out which potential vascular issue they may have. Are they not delivering enough blood there? Or are they not trapping the blood there? those two things are really important because it's going to sort of predict how they respond to certain medical treatments if you're trying to give them a solution for a blood flow issue. Lastly, you can have a neurological issue, so a problem of the nerves. We see that in people who have had long-standing diabetes, people who have spinal cord injury, people who have certain neurological diseases. So those are the sort of broad categories of physical causes.
So I want to ask about neurological issues and the trapping. So what is the basic mechanism that traps the blood in there?
So it would be nice if I could illustrate this. But
because the first thing I thought of was a cock ring, right?
A cock ring does basically what you should be able to do on your own by physically constricting the blood and not letting it leave there. But basically, we have veins that take blood out of the penis that exist on the periphery or on the edge of the chamber, the erection chamber that has the spongy tissue that expands when you get blood into your penis during arousal. In an ideal situation, the erection chamber rapidly expands as it fills with blood. Your penis gets bigger and it gets harder. And as that erection chamber expands, it compresses the veins that exist at the periphery. But there are certain conditions where men can develop scarring in their erection tissue, and so those areas of scarring don't allow for rapid expansion or sometimes incomplete expansion of that particular area, and so at that periphery, you have veins that remain partially open. So you're kind of leaking blood back into your systemic circulation when you don't want it to. I mean, you want the blood to stay there. So that's primarily how it's called venous leak erectile dysfunction,
right.
how that happens. And then, you try to overcome that using a cock ring by externally compressing the blood in the penis.
Thumbs up, thumbs down, cock rings. What is? I always wanted to ask
for
a urologist
kink or
this.
for like function.
Both.
I mean, I think that they're fine for play. Certainly, I think I counsel patients that they just need to be careful of what kind of cock ring they use, because obviously when your penis becomes engorged, it's bigger than it was when you put the cock ring on. So I have in residency had to cut cock rings off. So I usually tell patients to steer clear of metal cock rings because those are difficult to remove, and the last thing you want is an electric saw down there trying to cut through.
Have you had to do that?
Yeah.
Oh my God.
Yeah. The fire department was involved, but yes, I was there. But rubber cock rings I think are fine. And then in terms of function, it just really depends on the problem. So, I mean, if a man has really mild venous leak, using cock rings in combination with pills or sometimes even injections can be helpful. Some guys will use vacuum erection devices also in conjunction with those. But, I mean, I've had patients who have more moderate or severe venous leak who ask me if I think it'll be helpful. And in those guys, it really isn't. It just... it's not strong enough to sort of overcome their issue.
And so what do you do for them?
So for guys who have pretty serious venous leak, the gold standard of treatment is really a penile implant. Okay. So surgery, yeah.
And you don't do those, or you?
Yeah.
Oh, you do?
Mm-hmm.
Okay.
Yeah. It's like my favorite surgery.
It's your favorite surgery?
Yeah.
What do you like about doing penile implant surgery?
You know what? I think it's the most satisfying. Well, first of all, it's the most satisfying for patients. I mean, the satisfaction rate with penile implants like 95%. It's higher than any medical treatment we have for ED. And I think for a physician, it's very satisfying because you take guys who have probably been impotent, for the lack of a better word. I don't really like that word, but non-functional sexually for years a lot of the times, sometimes decades. I mean, it's and then you give them the ability to be as functional as they want to be. And so the penile implant takes a guy who probably couldn't get an erection, or at the very least couldn't maintain his erection. Now he has the ability to activate the device, have sex, and basically stay hard until he chooses to not be hard anymore. And so it's really satisfying, and can be life-changing. I mean, I've had patients tell me that it, saved their marriage and it, completely changed their life. I've had patients who were depressed for years because they couldn't have satisfying sex, who, got off medications. I mean, because they were the source of their depression was no longer there.
Yeah.
So,
Wow.
Yeah.
On the off chance that the listener out there isn't binge listening all my episodes and doesn't know exactly what a penile implant surgery is, could you kind of tell us what happens? We did talk about it in another episode, but
yeah. So basically, what we do is implant a device that.
How do you get it in there?
Well, there's different types of incisions you can make. I mean, we typically choose to do like a scrotal incision. Because you can sort of approach all of the things that you need to get access to through that incision. But some physicians will make like it's called an infrapubic incision, which is basically just at the base of the penis.
Okay.
Either one works, but basically through one incision, we kind of implant a multi-component device that's composed of 2 cylinders that are placed where your erection tissue is currently, a pump that goes into the scrotum, and a reservoir that holds fluid that gets circulated over and over again. And so what a man does basically when he wants to have sex is reaches down into his scrotum, pumps up the device, and it draws fluid out of the reservoir into the into the cylinders, until you get fully hard. So it provides the rigidity that you can no longer do naturally.
Mm-hmm. And it literally stays hard until they press
so
the
it stays
release
hard.
valve.
I mean, you basically become like the world's greatest lover because you stay hard until you deactivate the device. And so on the top of the pump, there's a button that you press that basically reverses the whole process. So it's a hydraulic system that basically just reuses saline fluid over and over again. Mm-hmm. But yeah, I mean, it's. I remember when I was a fellow, one of the male patients that we had said that he. His comment was he felt like he could have sex like a woman after the surgery. And my mentor said, well, what do you mean by that? And he said, well, I can literally lay there and my wife can, go to town basically. And I'm just, until she's done, I'm just, I can just read a book if I, he basically was saying he doesn't have to be present if he doesn't want to be, and for years he was probably really concentrating trying to like maintain his erection. But, so yeah, he was actually really happy about that. So the partner satisfaction rate is also really great too, because especially for people who are in couples, because it's such a big part of, being in a couple. Yeah. And if you can't have sex, now you have the ability to, so it can be really sort of life-changing for both people.
And does anybody say that after a certain amount of time it's uncomfortable to leave it hard, or? Yeah,
I mean, you definitely don't want to leave it hard for like hours and hours and hours, but because you can have complications from that, certainly. But most people are not leaving it hard for longer than a couple of hours, I would imagine.
Yeah.
Yeah.
And so what can go wrong with it? What do people come back for? Or
I mean, it's a mechanical device. So everybody gets counseled on at some point this is going to fail. So it just really depends on the patient's age. The average, life expectancy for one of these devices is 10 to 15 years. Okay. So if you have an older gentleman, he may just need one surgery and then that's it. If you have a younger patient, if they have a device failure at some point, they would have to have surgery to have it explanted and have a new one put in. So that's just something that all patients get counseled on prior to surgery. But that life expectancy is pretty good.
Okay.
Yeah.
And then they just come and get it replaced.
Correct.
Yeah. That's fine. All right. So you also said neurological issues.
Yes.
Can you test for those?
So there are ways of testing someone's sensitivity. It's called it's usually done through biothesiometry. So basically what you would do is use different modalities to test how sensitive they are. And we usually use the finger as sort of a comparative point. So when I was a fellow, we would often do vibratory testing. We would test hot and cold and basically put it on, put test their finger first, and then test the head of their penis and then both sides of the shaft to assess both of the different erection chambers and see if there was a discrepancy between how sensitive their finger was versus how sensitive their penis was.
Should they be the same?
Roughly, yeah.
Huh.
Yeah. The only problem with that is that we don't have... traditionally, there have not been ways to change that. So if you find that someone is not as sensitive as they should be, there's not really a way to fix that. Now, my mentor is doing a lot of investigating of neurological causes of erectile dysfunction, primarily focusing on the spine. So I don't know how many patients they have in their series, but he's reported on a few instances of patients with various sexual dysfunctions that are genital specific, where they've found spinal pathology. They do spine surgery to fix whatever spine issue there is, and some of those patients have gotten better. But that's sort of avant-garde kind of stuff, and he's really the only one that's doing it at this point. So, but he, as I mentioned, is sort of the guru in this field, and I think if anyone is going to push us to the next frontier in sexual medicine, it's going to be him. And
what's his name?
Erwin Goldstein.
Oh,
yeah.
Okay, so you've narrowed down to one of those three broad categories.
Yeah.
And let's say it's blood flow. And let's say it's not that bad.
Yeah.
What are their options? What are you sending them home saying, okay, this is what you need to do more of?
So, I mean, you can talk to people about, lifestyle, behavioral things that they can do to help improve their issue. I mean, certainly if they're a smoker, you wouldn't want to counsel them on quitting smoking. That's going to not only affect their erectile health, but their general cardiovascular health. If they're obese, maybe, and maybe have like some hormonal issue, you can talk to them about, well, if you lost some weight, your, hormone parameters would likely improve. So those are the two big things, regular cardiovascular exercise, healthy diet. I mean, there's a sort of saying in sexual medicine that what's like good for your heart's good for your penis. So, people are always asking me, well, what can I do in terms of diet or whatever to improve things? And I tell them just that, what your doctor tells you, the diet that your doctor tells you to, help your heart or help your cardiovascular health is exactly what you need to do to help your erectile health too. And that's, again, because it's all about blood flow, right? So if you are in the beginning stages of developing atherosclerosis, then, the things that your doctor would talk to you about in terms of trying to reverse that or prevent it from getting worse is exactly what you would need to do to help with your erections and help the blood flow to your erections.
Are there any magical foods out there that you endorse these days?
Not really. I mean, unfortunately, none of it's like there's not a ton of science-driven data out there looking at that kind of stuff. But patients a lot of patients like to feel like they're doing something other than just taking medicine for these issues. So I think giving them advice on how to eat healthier, heart healthier, is something that they can use as motivation to try to help with this issue.
I've been wondering, how do I know when to go to a urologist versus a cardiologist? Or do you sometimes send guys to cardiologists?
Yeah, so there's actually a fair amount of data that's been published in the last decade or so that has shown correlations between erectile dysfunction and cardiovascular health. Primarily that men will often present with ED before they would present with other symptoms of underlying cardiovascular disease. So it's been called the sort of canary in the coal mine in terms of predicting underlying cardiovascular disease that wasn't previously detected. So I have sent patients to cardiologists to be screened for other effects of cardiovascular disease if their initial complaint is ED and we find that they actually have a vascular problem.
Okay.
Yeah.
Now, you said to me before, off camera, you said to me that you only see, on a busy day, 10 to 12, 13 patients in a day. And I think, there's a larger narrative in our culture right now about how all these doctors are seeing 40 people in a day.
Sure.
And what's the difference between you and them, and why?
Well, I think to work in this space and to try to help address these issues, like it's impossible to see 40 patients. There's a lot of education that I have to do. So, my initial consultations tend to be longer than a doctor who's, treating primary care health issues. There's a lot of, like I said, these patients have been sort of circulating through the healthcare system for years a lot of times. And so if they didn't already have neurotic tendencies, they've developed those because they've been dealing with this issue for a while and it's not been addressed, and no one believes them and they feel dismissed. And so I have to then unpack a lot of that. So for me, it just it would not be possible to see that number of patients. And I think that's where patients and even providers who refer to me find my practice especially helpful, is that, patients walk out of here understanding exactly why they have their problem and how we're going to sort of fix it or address it as best we can. Not everything is reversible, but I can usually offer some sort of strategy to at least address whatever problems we find.
Okay. So do those initial consults get pretty frank and graphic about the sex that they're having?
Not necessarily in the specifics, but I just basically try to assess from them what their goals are. I mean, if you're talking about a gay man, for instance, like I will ask them, on their first visit, do they have a preference in terms of topping or bottoming? What is their goal? Because to top someone and to have anal sex, you have to be pretty rigid. And so if that's not a priority to them, then, that's important for me to know. Or if that's an absolute priority to them, I definitely need to know that, because we have to figure out a way to get them the rigidity that's necessary to top. So I ask those kinds of questions more from how can we get you to your functional goal. I don't get into the specifics about what kind of sort of day-to-day sex they're having or what their sort of sexual preferences are outside of that kind of stuff.
Okay.
Yeah.
I mean, do they ever start to just really open up about that stuff?
Sometimes, yeah. People, I get both spectrums. Some people walk in here and blush and say they can't believe they're talking to me about this. I've had other patients who are very frank about what kinds of sex they're having, and they're going to, a sex party this weekend, and they need to figure out how they're going to be able to stay hard the whole time. And so, yeah, I mean, I tell them, at the end of the day, I want them to be as honest and open as possible, because that's just going to help me be a better doctor to them and provide them the best care, because then I know where they're coming from and what their goals are. Okay,
so how does somebody stay hard for an entire weekend?
Well, I wouldn't advise doing that.
Attempting that.
That's something called priapism and can be a major, major problem. But, I have patients who use injection therapy. A lot of times they need it. They actually have real vascular issues, but they enjoy using it for sometimes, group sex situations. And I think I don't want to say unique, and I definitely learned this from my mentor, but a lot of my patients who use injection therapy, who, potentially could be at risk for developing priapism, like getting this, erection that lasts longer than 4 hours that you hear about on the commercials all the time, which actually is a medical emergency. But, when guys use injections, they are at real risk of developing that. So I, again, spend a little extra trying to prescribe the appropriate strength of injections that they're using, try to counsel them on what I think is an appropriate dose, and then also teach them how to administer the antidote. So it's the same stuff we administer in the ER if someone comes in with this problem, and it essentially reverses the erection. And just tell them, listen, if you have an erection that doesn't go away after 3 hours, I would advise you to use this reversal. And then the next time you inject, that dose that you used the last time is probably too much. So, I tell them they have to do a little bit of dose adjustment at home on their own. The goal being that they get an erection that, lasts however long they need it to last. But if you're getting to that 3 hour mark, you want the erection to resolve spontaneously on its own and not have to use the reversal. But they have the tools with them should they need to use it.
And I did talk about injections on the same prior episode, and remind everybody what's in these injections. Is it just a fluid of Viagra, of sildenafil, or what's in there?
No, so there are other vasodilating medications. I mean, I do kind of describe them to patients as sort of like a super Viagra that you're going to inject directly into your penis. So they work much more powerfully than Viagra and Cialis and the other pills because they're not absorbed systemically. I mean, they're literally being injected right where you want it to work. So, but the injections come as a single medication. They come as compounds of either 2 or 3 medications, sometimes 4. But they all basically function to maximally dilate the cavernosal artery so that you sort of bring as much blood into the penis as possible.
Was that what they were designed for? I know how Viagra was originally intended to be just a heart medication.
Right. I don't know the history specifically of injections, but interestingly, the injections have been around longer than Viagra and Cialis. So part of the reason that those medications have become so prevalent and successful is that for years, like through the 80s and most of the 90s, the only medication that was available was an injection. And it's, not the easiest thing in the world to get a guy to be excited about injecting himself when he wants to have sex. So I don't know how they were initially studied, but they've been around for a while, since, the 70s.
And do people, when they get them, also typically get the antidote, or...
No, so most patients don't. So, we see patients all the time coming into the emergency room saying that they used injections and they've had an erection for 24 hours, and it's a big problem. And depending on what needs to be done to make the erection go away, I mean, it can lead to worsening ED or sometimes medication refractory erectile dysfunction. So it's a big issue. So, I teach all my patients how to safely inject themselves with the reversal medication so that doesn't happen. Because there's a lot of shame, depending on what kind of sex they were having at the time of their priapism. It's not uncommon for men to just not seek help and to wait, the whole weekend, and then they come in on a Sunday night or they come in Monday morning to their doctor and they've had an erection for 48 hours. That's a major, major problem, and they're probably going to end up having to be operated on to fix this issue, and then they sometimes end up with permanent ED.
Oh, man.
Yeah.
But then they get a penile implant.
Then they could get a penile implant.
All
yes.
right. Okay, good. So one thing I was going to ask is when I met you, I introduced myself to you. It was at a pelvic pain talk. So is this a significant part of your practice as well, working with male pelvic pain?
It is, yeah. So I I have a pretty close relationship with several sort of pelvic floor physical therapists in LA, and so they refer a lot of patients to me to act as sort of like the medical adjunct to whatever myofascial or muscle issues that these patients have. So I am sort of becoming, without even really trying, sort of the prostatitis pelvic pain specialist in this area. So yeah, it's a pretty significant number of patients that I see.
What I notice out in life is that a lot of people don't know that men get pelvic pain.
Right.
What are some of the more common forms of male pelvic pain you're seeing?
So it can present, that's where it becomes, it can become challenging. And again, this is a space in which men are often dismissed and told that they're crazy, which is really unfortunate because a lot of these patients get better with sort of minimal medical treatment and physical therapy. But it can present in a myriad of ways. So men will often report pain with erection, pain with ejaculation, lower abdominal pain, testicular pain, pain in their perineum. Sometimes, burning when they pee. They think they have a UTI or some sort of STD. So it can present in lots of different ways. And sometimes it's even benign symptoms like just I'm going to the bathroom more frequently than I used to, or my stream is weaker than it used to be. And so they often will, see urologists or, sometimes just their primary care doctor and be given just sort of thrown medication at them or just, told that that it's nothing. You know, they get checked for a urinary tract infection. And it's not a UTI, so that they get dismissed as, you know, you're just stressed out or, you know, whatever it is. But yeah, it can present in lots of different ways, which I think is why it's challenging for a lot of providers who don't treat it a lot, because they don't believe the symptoms, or they don't see how pain in the testicle can be, you know, a pelvic floor issue, or, you know, is sort of a one symptom of a pelvic pain disorder, basically.
Right. And so when I meet those guys too, I find that a lot of them have gotten an automatic prescription of some kind of either a steroid or some kind of like a penicillin, like an antibiotic.
Yeah.
And it does nothing.
Right. Well, because I mean, most of these patients don't have an infection. Mm-hmm. So, but you know, historically, I think that providers, you know, want to feel like they are doing something, and so they just put people sort of blindly on, you know, broad spectrum antibiotics. And some of those patients do get better symptomatically. Okay. The reason that is usually the case is not because there's an actual bacteria that's being killed and that they're getting better, in that regard. But you know, a lot of antibiotics are really strong anti-inflammatories, and a lot of this issue is more inflammatory related. And so often, you know, the patients that do get better with antibiotics, that is the mechanism by which they're getting better, not because there's some, you know, bacteria that's causing their problem and it's being treated by the antibiotic.
You said historically.
Yeah.
In your studies, in your fellowship and everything, what is the history of male pelvic pain? Does it go back very far? Do you remember, or did you?
I mean, it's basically just taught as prostatitis.
Okay.
Yeah, in medical education, which is like a horrible name because it implies that there's some sort of, again, infection in the prostate, and sometimes there is. Mm-hmm. But most of these patients have, you know, these chronic forms of pelvic pain. It's not like an acute bacterial prostatitis where they're getting fevers and, you know, sometimes have to be hospitalized. And that is a real infection. But most of these patients have been dealing with this for 6 months, 3 years, you know, and it's a chronic condition, but it all kind of gets lumped in, at least in medical education, in the prostatitis category. And so the treatment ends up being the same. Everyone gets, like you said, antibiotics. Mm-hmm. And there's a big gap in terms of understanding the importance of the pelvic floor and incorporating that into their treatment plan. So I tell patients all the time who I see, you know, that they have a condition called, you know, chronic prostatitis, chronic pelvic pain syndrome. And the first thing I say to them, I'm like, it's a horrible name and I don't want you to freak out. Mm-hmm. Number one, chronic sounds scary to patients, and, you know, prostatitis is a bit of a misnomer. And I basically say, your problem is primarily a function of your muscles and connective tissue in your pelvis, and maybe some inflammation on top of that. And so medically, I'll help treat the inflammation. But you know, if they didn't already come to me from a physical therapist, they're getting a referral at the end of their first visit for sure.
Okay. It's weird when so many people haven't heard of it, you know.
Yeah,
and it's
so common.
Yeah.
And I, you know, especially like what I tell patients is, you know, some things that can cause flaring of symptoms is like prolonged sitting, stress, anxiety, right? Those all cause us to sort of tense our pelvic floors. Mm-hmm. And like, we live in Los Angeles, so everyone is always sitting in their car, mm-hmm. and then they go to work and they sit at their desk all day. We're all constantly stressed out and anxious. And so it's like you know, of course here, and I'm sure it's true in most, you know, large urban centers. A lot of people have this problem.
Yeah.
So yeah, it's very common.
Yeah. You'll always have plenty of business.
Yeah.
Or for a while.
Right.
Porn.
Yeah.
Guys ask you
that
about that.
That was a nice transition.
Yeah. Trying to cover everything. Guys come in, and do they say, is my ED because I watch too much porn?
Yeah, I think it depends on how they got to me. Some people have like read online themselves and they've convinced themselves that they have like a porn addiction. Uh-huh. Other people have already been seeing a therapist and maybe they've had that conversation with their therapist. So it just depends, you know, but the truth is that I've had patients who have believed that about themselves and have sort of cut back on porn. And it doesn't always help. Mm. So, you know, I try to discourage patients from thinking black and white regarding porn, and that it shouldn't necessarily be thought of as a bad thing in terms of how it relates to their sexual function. Certainly it can, you know, be a helpful thing in some situations. But like with anything, if all you're doing all day is watching porn and you're masturbating 5 times a day, and then you have an opportunity to have sex with another person, and you can't be physically or mentally stimulated in the same way as you can with porn, then yeah, maybe it's probably causing an issue. And that's where I think sex therapists and therapists in general can be helpful, sort of retraining that sort of behavior.
Mm-hmm. Any other times we can help? Or
I think you guys are helpful all the time.
No, I'm just kidding. But yeah, when do you typically refer or say, what do you see that you're just like, you need to go talk to
Well, I mean,
about
certainly
this?
if we do the sort of physical workup and there's no problem, which is pretty rare, honestly. So that's obviously where I would refer to a therapist. Anytime I feel like there's like a significant relationship problem, not like the relationship itself is problematic, but this larger sexual issue has caused distance, or, the partner now, doesn't want to have sex because for years, my patient couldn't perform, and now I've given him the ability to perform, and now the partner is sort of, like, well, I had to deal with this for years, and now I'm not interested in having sex with you. So there's lots of sort of relationship issues that can come up. Patients who are younger, I think it can be really helpful for, because if they've never had normal or satisfying sex, then they have a lot of anxiety about how is that going to look going forward. Now that we've addressed these issues and you've given me the tools, I think that therapy can be really helpful in those situations too. And I think just, if you have a generally anxious person who is, fluctuating, they have a good day and they're doing great, but if they have they wake up one morning and their penis isn't erect, and they call freaking out, like, well, for the last 5 days I had morning wood, but now I don't. What does this mean? And they start spinning out. Those patients, I think, definitely can be helped with therapy for sure, because I can only do so much in terms of giving them solutions for their physical issues, but if their anxiety is going to keep creeping in and sort of counteract what I'm doing, then I think it's really helpful.
And I think that's probably a good thing for guys to hear, that the occasional non-morning wood.
I mean, I don't get morning wood every day.
You never get morning wood?
No, I do. I just don't get it every day.
Not every morning.
Right. And
right.
No man gets it every morning.
Right.
Or necessarily wakes up with it. You might have it in your sleep. A lot of guys get it in their sleep and they just don't know, and then they wake up. But yeah, I mean, I have a lot of patients who like perseverate on that. Well, I had like 2 weeks and it was great every day, and then they have one bad day and it's just like life ruining. Right. So it's just about keeping perspective, and sometimes that's easier for a therapist to do, because I can't see a patient in the office every week to reassure them, but I think that's where therapy can be helpful, while we're treating whatever physical issues there are.
I've developed kind of a saying that I mention in sessions, and I haven't even actually run this by anybody, but you deal with women too. Mm-hmm. So sometimes I say something along the lines of, we don't freak out when a woman isn't as lubricated one night as she was the prior night.
Right.
And is that a good analogy? Like, do men sometimes just focus way too much on it, and there's less that we can do about it, whereas it's a lot easier to just use some lubricant?
Right. Right. Exactly. I think it just depends on the guy. I think if you have a baseline anxious person, and they have sort of a fixation with their penis, then, I mean, I get guys in here all the time that are asking me about this little spot and that little spot, and what I think yesterday my erection was harder than it was the day before. And, at the end of the day, I try to give them perspective and say, well, you had sex both of those nights, and you were able to complete intercourse. So just because your assessment of how hard you were happens to fluctuate from one night to another, doesn't, at the end of the day, really mean anything. Or try to reassure them that your penis looks completely normal. And I've had to tell patients, like, stop looking at your penis. Right. You're not allowed to look at it anymore. Yeah. Or don't go online and read about, all the things that it could be on WebMD or on Reddit or whatever, because, people can really go down like dark wormholes about this kind of stuff. So.
My social media person's been asking me to get sound bites I think that's the one. Stop looking at your penis right there.
Yeah. Sometimes I use the
advice.
more colloquial term. I don't always say penis, but yeah.
Okay. No, that I can only imagine. So what are some things that are just super normal, nothing to worry about, little spots here and there, what are other things that just guys can...
Oh, penis size is huge.
Penis size.
Yeah. No pun intended. But yeah, so people, there's also a huge discrepancy in how big their men perceive their penis to be, especially if you're talking about a guy who's had ED for years. Like, he will imagine that he used to be like 8.5, 9 inches, and then we'll do a penile implant surgery, for instance, or whatever, and his penis is now 7 inches, and he swears that from the surgery he lost 2.5 inches. And the truth is that there probably is some shrinkage, but the reason behind that is that for 10 years he hasn't been getting great erections, so the blood flow to that tissue has not been great, and you get atrophy, just like you would, your bicep would get smaller if you're not working out. Your bicep's going to shrink, so does your penis. So people always imagine how they were when they were 18, and now that they're 65, they think that they're going to be there once we get give them a treatment for their ED. But again, that's sort of playing with expectations and helping people have realistic expectations about what qualifies as normal, and
Yeah, and I'm sure guys will come in worried that their penises are too small.
Right. Yeah.
What do you tell them?
It's pretty rare that you see somebody who has a penis that's so small that it would, make it difficult for them to function. At the end of the day, I try to reiterate to patients, like, most partners don't care how big your penis is, above a certain size, which 99% of men are. They just care that it gets hard. Like, at the end of the day, right? If you can't get hard, that's going to be a problem for your partner. And so if your penis is on the smaller side, but you can get rock hard, you're going to please somebody.
Yeah.
Yeah.
Because my understanding of anatomy is that everything that they're trying to reach is within reach.
Right. Exactly.
Like G-spot, prostate, you're going to hit it.
Yeah.
With something on the smaller end of the spectrum. And
Right.
that's what everybody wants.
Exactly.
Okay. Well, that's good. So this has been great.
Yeah. Fun.
But, I haven't been asking anybody this, but I was wondering why you said yes to this interview. Like, what is it that, what do you think the world needs to know, and why should we be having conversations about erectile issues? And
I just think it's time that we stopped having shame and about these issues. I mean, as men in general, but women as well. I mean, there's a lot of shame that women experience too in seeking out help for their own sexual issues. But I think it's my goal to kind of help the larger community, even beyond my own practice, understand that it's okay to talk about these things. Oftentimes it is not strictly a psychological problem. It's not all in your head. And whatever physical things are going on that could potentially be causing problems, there are solutions for. So, I mean, every guy that comes into my office for ED, I tell them on the first visit, one way or another, we're going to get you an erection. Whether that be a pill that we prescribe, whether we put you on a hormone program, whether we give you injections, or you end up having surgery, I tell them, if you are willing to listen to my recommendations once we kind of do the whole workup, we'll get you an erection one way or another. So, there are solutions for all of the stuff that we find out there.
I felt that when you said it. What a nice message that must be to hear.
Yeah.
Looking someone in the eye, in your doctor's office and everything. I bet that's really powerful.
Yeah, I think so, because a lot of patients think that they feel hopeless a lot of times. Yeah.
Yeah. Okay, well, thank you so much.
Yeah, thanks for having me on.
And I'll see you out in the field.
Okay.
Thank you for having a hard conversation. All right.
Thanks, Tim.
Bye-bye. Thanks to the show's executive producer, Robin Morrison. Thanks to Kat Murphy, director of social media. Thanks to Team Scrub for the music. Thanks to the sound engineer, Ravi Carmen. Thanks to Brian Hui for naming the show. Thanks to Alex Pitts for the intro. Thanks to Arlene Asuncion for the logo. You can find this podcast at hardconversationspodcast.com or wherever you get your podcasts. You can locate me on Twitter at TimNortonLCSW or on my website for my private practice, timnortontherapy.com. You can also email us at hardconversationspodcast@gmail.com or call into our hotline at 662-626-4276. That's 662-MAN-HARD. Thanks to all my friends and family for brainstorming this show with me. Shoutouts to the sex-positive community, including sex educators, sex therapists, sex coaches, other fellow sex podcasters, sex surrogates, academics, the sexual health medical community, sex workers, the tantric community, and everybody else involved with having hard conversations. Bye-bye.